Thank you, respected chairpersons and the entire organizing team of AMOGS 2020 for giving me this opportunity. And a big congratulations to all of you for organizing such a beautiful conference, such a grand conference, and such a well-organized conference, I would say. And it's always a pleasure to come back to your hometown and present in front of your home crowd. And I mean, it's very relaxing, and it's like very, it's a big honor for me to present in front of you. So let us start with my topic of discussion, that is the uterine rupture. We know uterine rupture is a catastrophic event in the obstetric practice. We are all afraid of this entity the most, I think, in our practice. And because of the increasing trend of cesarean sections in our practice, there are more chances of we coming into this situation very often. It leads to the grave complications to the mother and baby, and diagnosis of which requires high degree of suspicion and clinical skills. And because of its non-specific presentation, because of its non-specific signs and symptoms, and very short time which we have for the management of these patients, it is the much feared event in the clinical practice. By definition, rupture uterus is defined as the disruption of all the layers of the uterus, including the serosa, that is the peritoneum, after 28 weeks of gestation. We consider it at 28 weeks because most of the mishaps, they happen later in the pregnancy or during the labor, which leads to the massive hemorrhage. The incidence, of course, it differs in the scarred uterus and unscarred uterus. Even in scarred uterus, the incidence is different for myomectomy, previous myomectomy, or previous cesarean section, previous classical section, or the different modes of incisions which we take for the cesarean section. But roughly, it is 0.07, that is 1 in 1,536 pregnancies. And in unscarred uterus, which is very uncommon these days, because of the active management of labor and because of the institutional deliveries that is happening, but still it is 1 in 8,434 pregnancies. And it also actually depends. In obstructed labor it is different, because of the trauma it is different, and the various risk factors that lead to the uterine rupture is, first of all, the scarred uterus because of the obvious weakening of the myometrium and the scar. Multiparity because of repeated childbirths, the uterine myometrium is weakened. Maternal age, because as the age advances, the fetal macrosomia increases, and that is one reason it leads to obstructed labor and ruptured uterus. Placentation, placenta accreta, increta, percreta, and placenta previa, these all weaken the myometrium, leading to uterine rupture. Injudicious use of oxytocics, and most of all, when we give underground misoprostol, which we do not have the record of it, then it also leads to uterine rupture. Multiple gestation and uterine anomalies. Multiple gestation and distension of uterus as such per se is not a risk factor, but it combined with the other risk factors it poses the danger of the uterine rupture. Uterine anomalies like the bicornuate uterus and unicornuate uterus, dystocia and uncoordinated uterine actions during labor. Invasive mole, it also weakens the myometrium. Different instrumentations like forceps and ventouse. Uterine manipulations like external cephalic version, internal podalic versions. Trauma to the uterus like abruption and external trauma. And covular uterus also leads to weakening of the myometrium. Now, unscarred uterus, the rupture is rare, and it is usually spontaneous. It is very uncommon. It's usually spontaneous, and it occurs later in labor, or most of the time it's in the obstructed labor, which is found in the grand multipara and inadvertent use of oxytocin. Rupture is usually complete, and it is limited, involves the upper segment. And non-obstructive variety is usually the fundal region, and usually it's complete. Now these are some of the personal collection of uterine rupture. You can see the uterine rupture in the lateral wall, and this is the picture of the rupture which is repaired. That is, this is the conservative management of the uterine rupture, where we did not go for the obstetric hysterectomy, we did repair here. So this is how you can see the repaired uterus and rupture site from the fundus to the lateral right margin. Scarred uterus, we know myomectomy, metroplasty, these are all the high risk factors for scarred uterus to rupture. mostly previous cesarean section. Direct trauma to the uterus is also responsible. Classical section, it usually ruptures in the later months of pregnancy and LSAS in labor. And incidence is 1 to 2% in the lower uterine segment and 5 to 10 times more in the classical segment. Now, what is pathology of the uterine rupture? Incomplete rupture. Incomplete means the serosa intact, rest of the layers are ruptured. Complete uterus, including the serosa, everything is ruptured. Scar dehiscence is the incomplete. The scar is not completely ruptured. Scar rupture is the complete scar rupture. So you can see here, this is the longitudinal rupture and the transverse rupture of the previous cesarean section. Site of rupture, usually non-obstructive types, upper segment and fundus. Obstructive types, anterior lower segment. Posterior wall rupture is common in the obstructed labor because of the pressure of presenting part on the sacral promontory. So, scarred uterus, the site of rupture, usually it is clean, fibrosed margins with less bleeding, so which is actually, we can repair there. Traumatic rupture after destructive operations can be very, very damaging because it also damages the bladder anteriorly, and it also it leads to broad ligament hematoma, which can be very damaging. Diagnosis is usually, as I already told, the symptoms are very non-specific: abdominal pain, vaginal bleeding, feeling of something giving way with acute pain, fainting attack, and it is usually preceded by the event which leads to the rupture of the uterus. Like we know we have applied forceps, we have applied ventouse, or we know that we have done external cephalic version and everything. Then signs, tachycardia is the most consistent sign of ruptured uterus. Hypotension can be because of internal hemorrhage. Suprapubic tenderness, and patient has the feeling of bladder tenderness, and she has a feeling of she wants to pass the urine frequently. Hematuria if the bladder is ruptured because of that uterine rupture. Then there can be signs of obstructed labor like the distension of the lower segment, or distension of the bladder, overstretching of the lower segment, etc. Non-reassuring fetal heart rate pattern, most consistent is the bradycardia of the fetus. Intrauterine fetal death is usually the manifestation of uterine rupture most of the time, because it is said that 10 to 37 minutes of time we have to manage the uterine rupture. Even in that time, if you manage uterine rupture, it is less probable that you are going to save the baby, because the damage is usually done for the baby, and it's for the maternal interest that you hurry up and do the laparotomy. Then you can see you can feel palpate the fetal part superficially easily. Then there will be cessation of uterine contraction, loss of uterine contour, shock, and signs of intraperitoneal bleeding. Then on PV examination, you can see that the presenting part has receded because it has gone into the abdominal cavity. Exploration of the uterus, and you can feel the rent after the delivery, and there can be shortening of the cord. It is one of the sign of uterine rupture. Radiological features, you can see on the ultrasound, you see identification of protruding portion of amniotic sac, endometrial or myometrial defect. You can see extrauterine hematoma, you can see, or hemoperitoneum in the free fluid. Diagnosis is of course by the MRI. Complications for fetal, the complications are very grave. Usually leads to hypoxia, acidosis, admission to NICU, and most of the time, as I said, intrauterine fetal death. Maternal, there can be severe blood loss, anemia, shock, bladder injury, and it leads to obstetric hysterectomy most of the time and can lead to maternal death. Management, the most critical part is we have to maintain the time frame of 10 to 37 minutes to manage these patients. We have to mobilize all our resources available to manage this patient in this particular time. So the first and most important is that you should have high index of suspicion, and you should not miss all the warning signs that the patient is giving you. And it should be there in the back of your mind all the time. First and foremost is you have to call for help. You have to call your colleagues, you have to inform your seniors, and you have to have a team which is going to help you. You have to call the surgeon, you have to call anesthetist, and quick history examination, secure an IV line, give her oxygen, blood for grouping, cross-matching, and treat the hypovolemic shock. Definite management is do laparotomy, call the general surgeon, give midline infraumbilical incision, which is quick. By that method we can easily enter the abdomen and either repair or hysterectomy. Now conservative surgical management depends on desire for future childbearing, low transverse uterine rupture, we can go for conservative surgical management. When there is no extension of the tear to the broad ligament, cervix or paracolpos, uterine hemorrhage can easily be controlled. Patient is in good condition and there is no history, there is no evidence of coagulopathy. Repair is done in the previously scarred uterus, as I said, because the margins are fibrosed, there is less bleeding, you can refreshen the margins and you can do the repair very well. But in that cases, peritonitis, septicemia and rupture uterus in the next pregnancy should be kept in mind. Usually it is combined with the sterilization operation if the family is complete. Hysterectomy is the last option. When there is intractable bleeding, when there are multiple perforation or rupture sites, when the rupture is longitudinal, low-lying, then subtotal hysterectomy should be done. It's a quick hysterectomy if the GC is unstable, but if the patient is in a stable conditions, then the most preferable is the total hysterectomy. If there is broad ligament hematoma, you have to open the broad ligament, drain the hematoma, secure the bleeding points, and then close it. Now, the most important thing is how we can prevent this. We can prevent it by identification of the high-risk cases. We should know which patients are going to land up in this complication. There should be proper documentation of her risk factors in your notes. Institutional delivery should be promoted. Early indoor admissions should be promoted. That is, it is said that for classical Caesar, 36 weeks of gestation is the time where the patient should be indoor. Proper documentation here, I would like to say, it's your responsibility to mention whatever you are doing with your patient, so that for the next pregnancy, the treating physician knows, the obstetrician knows which type of incision was taken, or what kind of complication was there. Then strict vigilance during labor should be there. External cephalic version should be done smoothly by the seniors, and there is no role of internal prodalic versions in modern obstetrics. Proper selection of cases should be done for VBAC, and it is advised that you have to know the scar thickness by ultrasound before posting any patient for VBAC. Then, of course, judicious use of oxytocics, prompt measures to tackle the prolonged and obstructed labor. It should not be there in the institution. No instrumental delivery through incomplete dialectal service. Exploration of cervix and uterus should be done after any instrumentation. MRP in morbidly adherent placenta should be done by a senior obstetrician, and there should be well-equipped labor room to tackle any obstetric emergencies. And acute obstetric emergency drills should be carried out frequently in the labor rooms. The prognosis depends on various factors like etiology, site of rupture, preceding event, maternal condition, and early diagnosis. So to conclude, the crucial time, as I said, is 10 to 37 minutes. You have to manage the patient in this 10 to 37 minutes. The earlier, the better the prognosis, at least for maternal point of view. Then we have, as I said, when in doubt, you have to act quickly and definitely. And the most important is there should be high index of suspicion. You should be ready to tackle the emergencies, and that obstetric emergency drills frequently in the labor room, they help a lot in this. So thank you very much for the patient listening.